The next session would now be chaired by Dr. R. Vinod Kumar, EB member, IAP Tamil Nadu State Chapter. May I now request the speaker of the first session, Dr. M.S. Viswanathan, Senior Consultant Pediatrician and Pediatric Gastroenterologist, to occupy the podium for his talk on diet and IEM. I request the chairperson to take over and conduct the proceeding.
In this session, we have two interesting topics. First one is diet in IEM. Yesterday, we had a panel discussion on approach to IEM, which has been moderated by Dr. Thangavelu sir. Following which, now we are going to listen about diet in IEM. This will be presented by Dr. M.S. Viswanathan. He is a senior pediatric gastroenterologist and nutrition specialist from Apollo Children's Hospital. He has been trained in UK. Presently, he is a central IAP EB member. He is my colleague EB member. He is a very active person both in academic and non-academic. He was a captain for IAP Tamil Nadu cricket team. I think he is the odd person for this topic. Over to you, sir.
Thank you very much. Good morning, ladies and gentlemen. Nice to see you all, and I thank the organizing committee for the invite. So, yesterday we had a panel discussion on the clinical scenarios. I'll be discussing on the diet aspect. I'll give a bit of background, then I'll go over the practical issues, and then I will mention about the different IEMs, particularly nutritional management. I'll give some take-home message. So, I will be using some brand names because this is to highlight the role of various specialist formulas that are available in the current Indian market. I do not have any conflict of interest. So you all know that as a group, IEM is a bit common than what we think. It's about 1 in 2,500 in Indian scenario. And for an essential newborn screening, what is important is an effective treatment, which should be early and appropriate intervention has to be done. And for this, you need to have therapeutic formulas, basically what we call them as medical foods. So basically, the successful intervention for IEM is actually a triumph of modern medicine. I like the simple diagram. A goes to B and B gets converted to C. If there is a problem in the enzyme getting converted from B to C, B accumulates, or sometimes A also accumulates, and there will be deficiency of C. Sometimes B can get converted to toxic metabolite D. Just you remember that. So if you see this very carefully, if the substrate deficiency, as in glycogen storage disorders, you have hypoglycemia, or you can have an intermediate product that builds up due to the toxic, and they can be toxic, like leucine, maple syrup, urine disease. Or you can, another product, bypass product like succinylacetone in tyrosinemia, or sometimes the entire cellular physiology can be affected, as in lysosomal storage disorders. So medical foods, what we need to know that is, they are specially formulated and processed for partially or exclusively central feeding, where the child does not have the ability to digest or absorb or metabolize any of this one, where you cannot provide a dietary management just modifying the normal diet, and this is what is medical foods. So there has been very clear guidelines done by the American College of Genetics, etc. And nowadays we do have products for many of the nutritional IEMs actually. And initially they were a bit monotonous, they were not in synchrony with the normal diet, so it was not easy for the children to take it. Nowadays there are many products available, and both locally and as well as from international markets, and they are now easy to take, and moreover they are available in different forms, and they are age specific and condition specific. So, like they are available in 3 categories, like powder, they are ready to be used, like a ready-made drink or powder. They are usually nutritionally complete, apart from being devoid of the offending the particular product. Modular diet, here you have only certain group of products available, like amino acid mixtures. So, which means this is not nutritionally complete. So, you need to remember that. Sometimes you can just modify the food to be low in protein or offending substance, like cheese substitutes, etc. So these are 3 ways where you can have medical foods. So what happens if you do not institute therapy early? For you all know that PKU, if you don't treat them properly, they can have long-term effects, including an adult onset psychosis. If you don't treat a pregnant mother properly, they can fetal PKU with microcephaly, all sort of things. If you don't intervene homocystinuria, they can have stroke-like effects. If you don't intervene acetyl-CoA deficiency, it can result to cardiomyopathy and sudden death. So as I mentioned earlier, the treatment of IEM has to be lifelong because they are all basically genetic disorders and autosomal recessive, most of them. So this has been approved and this has been recognized by various academic societies across the world. So what is the cause? I'm just starting with the cause initially itself, because this is one thing which we are worried about. For example, PK is one which has been studied very well, and for that the annual cost for an infant is around $1,200. For us it goes up to $2,500 for a child, and for an adult it goes up to even $8,500. If you use exclusively medical food, this is a problem. Sometimes if you use a combination of medical food and a diet modified, you can reduce the cost to approximately $8,000 per year. But if you just talk about only the cost of medical foods, if you don't use them, what happens? You have a child who is intellectually disabled, and the parents have to care for them. They can't have a social life. School time is missing. Work is missing, particularly in adult symptoms. So we need to consider this when you talk about cost factor all the time. So therapeutic enteral formula was not available earlier in India. As a society, ISPAGAN, Indian Society of Pediatric Gastroenterology, liaised with the central government and FSSAI, which is Food Standards Safety Authority of India, wherein we were able to get approval for many of the therapeutic products. And this FSSAI launched this Diet for Life initiative to create an ecosystem for IEM products. And this is the website, you can look into that. So, the idea of nutritional treatment just is first is avoidance of fasting to prevent the catabolism. Then of course you reduce the offending products or you make them free of that particular product and supplement the end product that is essential for the metabolism. Then low protein foods are needed for amino acid disorders, and medicines, vitamin supplements may be needed in some of them. And most important you need to remember is lifelong therapy is a need. So this is the particular article we have published in Indian Pediatrics couple of years ago. This lists all the products that is available in India and approved by FSSAI. I will be quoting some of these products during my talk. So they can be classified as a low lactose, lactose free or hydrolyzed or IEM formulas, or they can be MCT based formulas. I'll be focusing more on IE specific formulas today. You all know that IEM can be classified broadly as protein based disorders. Typically, you have amino acidopathies, organic acidopathies, or can have urea cycle defects. And in fatty acid oxidation, you have long chain, short chain and medium chain disorders. Carbohydrate, typically galactosemia and glycogen storage disease. So here, I just started a case scenario. A child who was born to a non-consanguineous parent, uneventful delivery, fed with the standard infant formula. Jaundice came at around 4 days of life. It was significant jaundice, treated with phototherapy, as then the child was started on some sort of coarse milk based formula. When then the start, the child did have significant issues, then child transferred to neonatal intensive care, then they put it on hydrolyzed formula. The child did show some improvement. Then what happened after that period of time, they did also look at metabolic disorders, sepsis, echo, everything was negative. So after the period of few weeks, they put the child back on standard infant formula. Again, the child didn't do very well. So they were referred to me because of this issue of deranged liver function test. Transaminases was raised and there was coagulopathy. And what I did was, when I have a child who is presenting very early on life with this sort of things, always you need to look for galactosemia. A urine resistance was just positive, and then this was confirmed by, looking at the GALIP, which is galactose 1-phosphoryluronyl transferase. So what happened here? We have commercial lactose-free formula, and there is complete normalization of biochemistry. And this is the typical enzyme you need to remember, that galactose 1-phosphoryluronyl transferase, which there is no conversion of galactose 1-phosphate to EDP galactose, this accumulates and that results in all the problem. This is classical galactosemia. And then they can have initially jaundice, they can have hypoglycemia, they can have hepatomegaly, later on they have kidney damage, they can have cataract and learning disabilities and galactosuria. So main thing is basically this is the only condition if I say that you are not going to give any breast milk, or probably very long chain fatty acid early on in infancy, you don't have to give it. Otherwise, breast milk is usually indicated in all IEM as a good source of protein. And the thing is, so basically you can go to lactose and galactose, you are going to restrict in the diet, and you have to supplement calcium and vitamin D. You have to remember there are bound galactose and free galactose. Bound galactose, you don't have to worry about that. They do not add to the free galactose pool. However, you need to be careful about the free galactose. They can add to the free galactose pool. And these are the various formulas that are available, which are soy protein based in our setup. And these are the various milk protein based available in our setup. I want to highlight one important thing. Simile MCT is not a MCT formula. It has got only 7.4 MCT. It's a lactose free formula. So I want to know you to remember this is a misnomer actually. You need to be careful about that. Sometimes you can use amino acid formulas if the child is not doing very well, if you want to buy some time, because they are also lactose free. These are the various protocols which we have quoted in our article, particularly for galactosemia. And we talked about exogenous galactose. Endogenous galactose is also there. So basically you need to remember that can also contribute. You know, this one, if you look at this particular, the red chart, the red bar, it has got, you know, at least an adult with galactosemia makes approximately 10 times more galactose in his body than he gets from the galactosemia diet. So this is also an important thing which you only need to remember, and these are the guidelines, you can look into that. So the second case is, you know, a child who presented with abdominal distension, poor oral intake, not interested in playing, gets tired, no history of jaundice, hematemesis or melena. So examination wise, you know, the anthropometry was the lower side, cheeks chubby, significant hepatomegaly, and the spleen was not filled. Hemoglobin was 11.3, AST, ALT was high, and the prothrombin time is bit high, gross hepatomegaly, otherwise unremarkable. So liver biopsy did show rarefied cytoplasm, well-defined cytoplasmic membranes, suggestive of metabolic storage disorders, likely glycogen storage disease, and the genetics did confirm GSD type 9. I want to just remember in this entire chart, I just want to remember this particular area. Glucose 6-phosphate is getting converted to glucose by the enzyme glucose 6-phosphatase. And this is a very important step, because this is the final step for both glycogenolysis and gluconeogenesis. And this is your type 1 GX disease. And these are the various genetics for the GSD. Probably you might have known up to 9, and now the up to type 15 is available. And I also want you to remember this particular slide. You know, when this is a fasting state, basically the glycogenolysis, gluconeogenesis happen, and you have a blood glucose. If it doesn't happen, the fat has to go for a lipolysis, and then that provides a source of ketones. And similarly from brain, you know, the ketones are the main source of energy for the brain and the heart. The problem with GST, particularly hepatic GST, is liver don't have enough reserve of glycogen. So basically they are prone for hyperglycemia. They can be where both glycogenesis and gluconeogenesis was affected, as in type 1A and 1B. There is only a defective glycogenesis as in type 3, 6 and 9, or altered storage of glycogen in other types. One thing what you need, that's a good source of modified diet is available, which is cornstarch, and you need to remember it's a raw cornstarch is very good, that releases carbohydrate slowly, whereas the cooked cornstarch behaves as a normal carbohydrate. So you can do a continuous nasogastric, intragastric feeding, particularly in infancy, and the rate will be around 7 to 9 milligram per kilogram for less than 6 years, and it is around, you know, more 5 to 6 in older children. So you need to remember there is also the dose available is around 2 gram per kilo of cornstarch. You need to be careful, particularly using children less than 1 year, as they can have issues about digesting because of less of pancreatic amylase activity. Timing, you should give the first morning feed immediately or 30 minutes after discontinued nocturnal feeding, or 4 hours after the night dose of cornstarch. You need to maintain this kind of proportion in GSD. Avoid definitely restricting the fruits, milk, sugar as they get converted to lactate and lactic acidosis results. And these are the various infusion rates I mentioned earlier. And there is also some recommendation about the protein source. You know, 3 you can give around 3 to 4 grams. For other types you can give around 2 to 3 gram per kilogram per day. And these are various food allowed and not allowed in GSD. You can take the photo, because I don't going to discuss that for lack of time. And in GSD, apart from this, you need to remember you need to supplement the vitamins, because they are more prone for osteoporosis. And in GSD type 1B, you have to give vitamin E, because they are at the risk of this neutrophil dysfunction. Amino acids going to amino acids, and amino acids can get transaminated to ammonia, enter the urea cycle. They can go decarboxylation and provide a carbon skeleton for all this source of, you know, other products. So I had a 8-month-old child who presented with vomiting, poor irritability, distended abdomen, significant coagulopathy with some sort of episode in the neonatal period, was diagnosed as sepsis. Did have an hepatomegaly. These are evidence of chronic liver disease with shifting dullness, bleeding, spleen palpable, and very low birth, very low weight at presentation. As you can see very clearly, ALT, AST around hundreds. The important thing is INR is around 4.2 to 4.6. Virological workup, other metabolical workup apart from metabolic acidosis were unremarkable. Have a significantly raised alpha fetoprotein and urinary succinylacetone acetone is positive. Basically, this confirms the diagnosis of tyrosinemia, and this is basically an infant presenting acute liver failure. I did have to go with all this therapy for this child, but this child has significant ill issues, so we have to go for a living donor liver transplant. However, I just wanted to go to this tyrosinemia flow chart. This is the enzyme which have a problem in tyrosinemia type 1, fumarate acetoacetate hydrolase. Because of this, these two accumulate, and these are very toxic products. So what happens? They can have a severe liver disease in young infants. They can have signs of renal disease or rickets, and then they can have neurological crisis. So what we do in tyrosinemia, basically, we are trying to convert this type to this type by giving NTBC, which is basically nitisinone. Though these are very toxic, tyrosine is less toxic compared to that. So basically, this is what we are trying to do with the medicines. But however, if we do that, we have to make sure the tyrosine level does not go beyond 600 micromole per liter. So we need to play with the diet also. And these are various products available in the market for tyrosinemia. Apart from tyrosinemia, you have these products available in Indian market for PKU, homocystinuria, urea cycle defect, maple syrup urine disease, hyperglycemia, and various organic acidemia, MMA, PA, isovaleric and glutaric acidemias. Long chain fatty acid oxidation disease. Why you need to remember is these are diseases, long chain and medium chain fatty acid oxidation defect. You can prevent problems actually. So you need to know that because they can result in cardiomyopathy, arrhythmias, and sudden death. So basically what you need to avoid fasting, particularly you need to give extra carbohydrate during physiological illness or a stress or exercise. And then also for LCAT you can give MCT based diet. And this is the various sort of the maximum duration you can allow between feeds. For example, 4 months for 4 months you can maximum of 4 hours fasting. For infants you can have a maximum fasting of 10 to 12 hours, not more than that. MCT formulas, the reason is they are basically having a 6 to 12 carbon of the passively diffuse from GIT to portal system without any emulsification. So it's easily absorbed independent of bile salts or lipase. And there are so many indications for that. One of the indications is the long chain hydration deficiency and continental palmitoyl transit deficiency. And these are the various MCT based formulas available in Indian market. And MCAT, as I mentioned earlier, similar to LCAT, you have to avoid all the stresses, you have to make sure to prevent hypoglycemia. They can present a Rayleigh syndrome, one need to remember that. And again, the most important thing you need to remember in MCAT is you have to avoid MCT based diet. People keep giving all this MCT oil just like that without really this is MCAT deficiency. The reason is this is also one of the reasons for a sudden infant death syndrome. This has been reported very well in UK. There are other specific formulas available in IEM. They can be like completely amino acid free. They can be completely fat free. They are completely carbohydrate free. So my take home message will be breastfeeding can be given in many of the IEM except for galactosemia, definite contraindication, and to some extent very early infantile LCAT. Medical foods are essential modalities in the management of IEM. I think what as a society, as a policy makers, we need to make sure is medical foods to be covered very well by insurance companies because they need this for lifelong. GST nutrition management have really changed the scenario. From once a fatal disorder, now people are living lifelong. FAOD, the main thing is avoid fasting, give additional carbohydrate for an exercise, stress, illness. Most important thing, counsel the family, tell them to come to a hospital immediately as soon as the child is ill because they can go downhill rapidly. Most important things, you need a team, a specialist with a dietitian and a very responsive lab. You just don't send the samples to any lab. That lab has to be responsible what we asked for. They need to be very clear what they say. And of course, you need to involve the parents. So, lactose-free formula can be soy-based or milk-based, and they can be used in galactosemia. And you can use amino acid formula in some of them, they are lactose-free. MCT-based formula, at least they need to be the formula should have a 30 to 70% before you label them as MCT. They can be used in long chain fatty acid oxidation disorders, but not in medium chain acid disorders. There are various disease specific formulas available for various amino acidopathies and organic acidemias. Always involve the specialist very early, including a specialist dietitian. You wonder why I am putting this slide. You have Sachin and Saurav here, you have Batman and Robin, you have Neymar and Messi, and you have our many stars like Kamal and Sridevi. They are inseparable combos in the field, whatever they have chosen. I am trying to tell you that diet and IEM are inseparable. They need to go together. So again, you can go and look at this article. And I want to thank all the mentors and the children whomever I learned, wherever I worked, both in India and UK. And this is my contact number if you want to contact me for anything. And thank you. I want to say that you need liver to live, and you need a healthy liver to live longer. Thank you very much for your patient listening.
Thank you, sir. Thank you for finishing in time. It's a wonderful presentation. Sir clearly highlighted about 3 categories of medical food and how long it should be taken and cost factor, and also highlighted about various therapeutic enteral food, and also presented with the case scenarios for better understanding.
Thank you, Chairperson. Thank you very much.
If any questions, it will be taken at the end of the session.
Thank you.